Well, good afternoon, everyone. I have 1 o'clock, so we will go ahead and get started. Welcome to today's APIC Great Lakes March education session. For those of you who I don't know, my name is Kelsey Ostergren, and I am joined by Chow Nguyen, and we together are the APIC Great Lakes Education Co-Chairs, mouthful. So hopefully you've been enjoying a packed week of education. I know NHSN training is going on right now. So we're glad to have you. We know this conflicted, so our apologies. This session, as well as the NHSN sessions, will be recorded. So hopefully if you can't hang with us for the full hour, you can come back and revisit that session recording later on. Today's session is actually a kickoff to our 2022 education series. As you know, we love to be able to offer virtual and in-person infection prevention education. And today we are thrilled to be joined by Dr. Bagdsasarian. And before I introduce her, I just wanted to do a couple brief housekeeping announcements. As I mentioned, the session recording will be available, as will the slides from today. So look for an email with more information on that. And the other thing, as always, is we love for these sessions to be interactive. So as Dr. Bagdsasarian is presenting, please feel free to use the chat box, enter any questions or comments. We're hoping to have time for Q&A at the end, so we will be using that chat box to guide that discussion. So please, again, feel free to add any questions or thoughts there as you're listening today. So with that, I will introduce Dr. Bagdsasarian. She is the Chief Medical Executive for the state of Michigan, in which she provides overall medical guidance for the state as a cabinet member of the governor. For the last year, Dr. Bagdsasarian served the state of Michigan in the role of Senior Public Health Physician with the Department of Health and Human Services, where she oversaw the SARS-CoV-2 testing strategy and helped bring rapid testing technologies to vulnerable populations. She has served as a consultant for the World Health Organization since early 2020, providing technical guidance on outbreak preparedness and COVID-19. Dr. Bagdsasarian completed medical school at Wayne State University, an internal medicine residency and infectious disease fellowship at the University of Michigan, and received a master's in public health degree in hospital and molecular epidemiology from the School of Public Health at the University of Michigan. She is board certified by the American Board of Internal Medicine in both internal medicine and infectious diseases, and has been elected a fellow of the Infectious Disease Society of America. She has worked in Michigan and internationally for the last decade and has 40 publications on topics in infectious disease and public health, including guidance on infection prevention and control of SARS-CoV-2. She's held teaching appointments at the University of Michigan, Wayne State, and the National University of Singapore, and has won several teaching awards. With that, Dr. Bagdsasarian, we are absolutely thrilled to have you. Thank you so much for being with us today, and the floor is yours.
Thank you so much. I'm so thrilled to be here with this group. As I mentioned, I spent much of my career working in infection prevention and working in hospitals. So this is a group that is near and dear to my heart. And I'm really excited to be able to share some information. I will just a couple of caveats before I begin. Number one, the title today is COVID-19 surveillance and epidemiology, but I have kept this kind of big picture, broad. And I've tried to make this very forward thinking and what is the future going to hold. So we'll talk about some of those big picture items. And I also tend to speak quickly and my presentations tend to be short. So we should have lots of time for Q&A, and I hope that you can stick around and that you've got lots of questions to ask. So with that, I'll get started. Can you see my slides okay? Okay, great. So this is the new COVID-19 community levels from the CDC. And this is a very different look at not only the state, but also the entire country compared to previous CDC metrics looking at COVID-19, where we were focusing mostly on cases, but also percent positivity. The new metrics take into account not only cases, but hospital burden, which is really important in the current phase of the pandemic that we're in and the goals that we have in this phase of the pandemic. And I'll go through some of those a little bit later. But you can see the general idea is that most of the country and the vast majority of the state is in a low risk, level right now. So things are looking positive from that perspective. And I'll go through some other We'll get into the details next. So we've really been seeing cases going down, and there was a time when cases were going down very rapidly. Some of those reductions in case rates around the state have been plateauing in the last few days to weeks. And what that means, I think, is a little bit up in the air right now. We also have specifically a decline in case rates slowing in the school-age population statewide. And as you know, some of our guidance on masking and mitigation strategies has changed a little bit recently. Cases continue to decline in staff and residents in long-term care facilities. I bring this up only because long-term care has been one of those very high-risk settings since the beginning of the pandemic, a place where there are vulnerable patients, so vulnerable in terms of age, comorbidities, risk of progression to severe outcomes and death, and also a place where, of course, as you all know, disease transmission can happen very rapidly, and outbreaks can also happen very rapidly. So cases have been declining, which is really wonderful. We have continued to emphasize the importance of vaccination and boosters in our nursing home residents as well as our nursing home staff. And that has been an ongoing project for the state. Hospital admissions due to COVID-19 continue to decline. And this is really good news. This is happening around the state in all regions as well as in all age groups. Some of the declines have turned into somewhat plateaus, but again, we're in a range where things are more sustainable for the healthcare systems, as you all know, given the fact that you are working in healthcare systems. And so we're following this trend again quite closely. I did want to touch upon some of the issues with COVID-19 and disparities that we've really been seeing over the last 2 years. Because even though things are at a very positive overall picture around the state, we have to keep in mind that not all communities have been hit in the same ways, and uptake of our tools have not been homogeneous across the state in all communities. And so this is a look going back to the beginning of the pandemic, looking at daily deaths per million by race and ethnicity. And what you can see here is that the very first surge we had back in March of 2020, and this was a time where we didn't have sufficient testing supplies initially. So whether or not we were even picking up on all of our cases, we didn't have vaccine, we didn't have therapeutics. So this was a time where things were quite different than they are now. But what you saw early on in the pandemic was that African-American communities were hit the hardest, especially when it comes to severe outcomes and death. So you can see this peak looking at African-Americans specifically was much, much higher than for other racial groups. Now that disparity and that inequity was reduced moving forward. We still saw the highest peak in the second and third waves in American Indians and Alaskan Natives. So again, there were some disparities, but the difference between the lower risk groups and the higher risk groups was reduced. Then in our most recent Omicron surge, again, we saw some of those disparities reemerge, especially with African Americans being hit hardest during the latter half of that Omicron surge. And this really goes back to uptake of some of our tools. And again, I'll talk about that a little bit later on, but COVID-19 has really showed us some of these healthcare disparities and underlying disparities in the overall health of communities that I think we really need to look at in order to build back stronger public health systems in the future. These were recent case rates, and this was looking specifically at that Delta and Omicron surge that we had sort of back to back. And you can see that even though the peaks were not nearly as different as they were when we looked at the previous graph looking at death rates, there was a difference when you look at different communities. So with this Delta and Omicron surge, what we saw was that African-American communities were hit first and hit hardest initially. And then some of that sort of leveled off as time went on. Again, has a lot to do with uptake of tools and vaccination, which we really need to look into and talk about how to do better But again, our racial disparities, despite all of our best efforts and all of the work that the states and all of you around the state have put into this, there are still disparities. This was a recent MMWR that looked at hospitalizations among adults during the Delta and Omicron surges. And this is data that we don't have at the state level. So we don't have race and ethnicity by hospitalization. But what they showed was that during the peak of Omicron, COVID-19 hospitalization rates in African-American adults were 4 times as high as those among white adults. So this is concerning. And again, we have tools to reduce some of these disparities. We really need to work on how we get those tools to vulnerable communities. I had mentioned vaccines being one of those tools that it's so important to make sure that we have equity at looking at vaccine initiation and also completion of vaccine series. So when we look at vaccine uptake by race, what we see is that there are differences. There are clear differences both with initiation and with completion. So you can see that for vaccine initiation in non-Hispanic white populations, we're at 56%. In non-Hispanic Black populations, it's down to 44%. So a clear difference there. When we look at Asian, Native American, and other Pacific Islanders, initiations as high as 66%. And in Native American and Alaskan Natives, we're down to 59%, Hispanic 62%. So really, the one number that seems to stick out the most is our African American vaccine uptake rates. And it's something for all of us as being involved with healthcare and providing healthcare in whatever capacity. We really need to think about why this is happening and what we can do to combat this. One of the specific things that troubles me the most when we look at vaccine uptake is that not only do we have differences by racial and ethnic group, but we also have differences by age. And some of those differences are really compounded when you put those factors together. So I'll show you what I mean here. So when we look at vaccination uptake across the age spectrum, so the top graph is all races and ethnicities. What you'll see is that we've done fairly well when we look at those over the age of 65. So in 65 to 74 and 75 plus, we're at between 86% and 89% vaccine initiation, which is good. Not as high as the national average, but still very good. And when we look at our average vaccine uptake, I must point out that Michigan is below the national average. Now, when we start looking down across the age spectrum, you can see that with each decade of life, vaccine uptake drops until we're down to 27% for those age 5 to 11 years old. Now, if we look at just African-American populations, and again, we know that overall vaccine uptake is lower, but when we look at this age distribution, what we can see is there are some ages, some age groups that are more at risk because of vaccine uptake. So what we can see is that our 65-year-olds, it is not too bad. We're at 68%. 75 plus is a little bit lower, which is surprising because this tends to be a group that doesn't have a lot of vaccine hesitancy. And then again, you see that drop down the age group, but specifically among those who are age 20 to 29, there does seem to be a big drop off in vaccine uptake, with initiation being as low as 30%. So that's concerning. And then when we look at 5 to 11-year-olds, we're down to 16%. And when we look at certain communities around the state, when we look at Detroit, for example, that drops down even lower to around 12%. And so this is something that we really need to think hard about, because if we want to move forward from this pandemic as a society, as a state, we have to think about those who are the most vulnerable among us. And we really won't be out of the woods so long as we're not all protected, so long as all communities are not equally protected by the tools that we have available. So I'll talk a little bit next about moving into the next phase of the pandemic. And this is where we are talking a little bit less about the surveillance and epi data that I'm sure you all wanted to hear about, but more about the big picture and what this looks like, both to average citizens as well as to people who work in healthcare. So I'll start out by just talking about the tools we have available, because it's nice to make sure that we're all using the same terminology and you know what I mean when I talk about tools. So the tools that we have available to us now at this stage of the pandemic are, of course, vaccines. So we know that vaccines reduce the likelihood of severe outcomes, hospitalizations, admission to an ICU, and death. And we now have vaccines available for everyone ages 5 and up. We've got boosters for those ages 12 and up, and more boosters may be announced at some point in the future. We're also waiting for a decision for vaccines for those under the age of 5. So vaccines are really the pillar of our tools in terms of moving forward. We've also got testing. So not only do we have the PCR tests that have been the mainstay of our testing since the early days of the pandemic, but we've also got antigen tests, and over-the-counter tests have been an absolute game changer. So we really support the use of over-the-counter tests because it allows people to test when they want to. So when they feel they're at risk, if they have symptoms, you can test as soon as your symptoms develop. You can test in the comfort of your own home, in the privacy of your own home, without having to necessarily disclose that test result to anyone that you don't want to, with, of course, some caveats that we do want you to tell people who you may have exposed. So we really support the use of these over-the-counter tests, even though it means we may not capture all test results, because again, we're moving into a different phase of the pandemic. When I talk about treatment, we're talking about both monoclonal antibodies that have been around for some time now, and that again, reduce the risk of severe outcomes and death, but also oral antivirals. So medications like Paxlovid have been absolute game changers in terms of reducing the risk of death and severe outcomes for those who are at significant risk. And then we've got things like Evusheld, which is the long-acting monoclonal antibody that can be used for pre-exposure prophylaxis for immunocompromised patients who are most at risk. And then, of course, we've got masks, distancing, and ventilation, our non-pharmaceutical interventions, which have been around for a while, but we now have access to high-quality, well-fitting masks, which I don't need to tell APIC what a high-quality, well-fitting mask is. You guys are the experts in this. But we now have masks that can be used that are more for protection of the wearer rather than simply for source control. Still a lot of work to be done around the state and around the country on ventilation. But when I talk about the tools that we have now that perhaps we didn't have access to in the same way a year ago or 2 years ago, this is what I'm really referring to. So with those tools in mind, we have to think about where we're heading in the pandemic and thinking about this in terms of a pandemic frame shift. So we are moving into we are moving from a situation in which surges and increases in cases had been rather unpredictable to hopefully a situation where surges and increases in cases are more predictable. And we can already look ahead and say, when do we expect surges? When do we think we may see another increase in cases? So it's likely that future increases in cases will be around seasonal changes. So the weather, we know that the SARS-CoV-2 virus really likes dry, cold conditions. And we know that indoors, in settings that are not well ventilated, the way people congregate indoors over the winter make perfect transmission settings for SARS-CoV-2. We're also looking at societal changes. So schools reopening in the fall, for example, that was a time that we've seen some surges in the past, and it's possible that that may be seen again in the future. And then we're also looking at new variants as being a potential cause of future surges. And that's a little bit harder to gauge, but we can see what's happening in other parts of the world. So when we look at next surges, there could be a surge in the fall of 2022. There could be a surge in the winter of 2022, 2023. There could also be a surge sooner, depending on variants of concern and how they're behaving. And I'll talk a little bit about that in a moment. So our messaging to the public, and the reason why I thought it was important to share this with this group in particular, is because it's really nice if we talk to the public in the same way. And you all are involved in the public health sphere. So I think it's nice to sort of get on the same page in terms of terminology. So we're really talking about a proactive rather than a reactive strategy, and really predicting when we're expecting future surges and then messaging that out to the public, messaging that out to partners in healthcare, and really making sure that people around the state understand where we are now and what we are expecting in the near future. I have put just a few seasonal trends of some other respiratory viruses on this page, and these are all trends and viruses that you all are very familiar with. But there are clearly seasonal trends when we look at things like influenza and RSV, for example. When we look at adenovirus and other coronaviruses, again, there are seasonal trends, but perhaps they're not so clear cut. And what I would expect with the SARS-CoV-2 virus is that we would end up going from a less predictable model of increase in cases to perhaps something that looks a little bit more seasonal and a little bit more predictive. And as that shift happens, and I don't know how long it will take for things to become more predictable, we do expect there to be significant variation by region and also lots of local outbreaks and hotspots of concern. So rather than this being a statewide issue all of the time, this may end up being more of a local issue, more of a setting specific issue. So there could be healthcare facilities and long-term care facilities with an outbreak rather than this being a statewide phenomenon. And this is the way that we are really messaging out this response cycle, we're calling it, to the public as well as to any partners in healthcare and any other public health partners. So we're thinking about the response phases as being very cyclic. So we just went through a response phase, which was characterized by that Delta and Omicron surge back to back. And this was a rise in cases. It impacted our hospitals. It impacted infrastructure. We saw an increase in morbidity and mortality. And so it was all hands on deck. We were sending out supplies for testing, masking, therapeutics. We had lots of messaging around masking and testing and social distancing. And we've now entered into this post-surge recovery period. And in this recovery period, we are okay with members of the public dialing down some of those mitigation strategies, but with the understanding that the pandemic isn't over, that we will see future surges, and that from a public health standpoint, we are not in recovery. We are actually in preparedness. We're looking ahead, we're doing horizon scanning, and we're looking for threats in the future. When we do feel that there is an imminent threat, we would enter as a state into this readiness period where we're really messaging out what's coming next and what we want facilities and individuals to do. So this is the way we're thinking about the pandemic cycle. And as we go through this, because I do anticipate we would go through this a few times, we would expect recovery to feel more and more like normal life. And we would expect response to be less and less disruptive. So the goal is to cycle out of this, to cycle through this a few times until eventually we're in a place that seems more like our normal life. Again, with the lessons that we've learned from COVID, but a little bit more like our normal life. And so in this post-surge recovery period, we have issued some guidance around isolation and quarantine. We've issued guidance around masking. And this guidance, I'm putting this up here just as an example, we do expect it to change as our conditions around the state change. And it's somewhat difficult to predict how this messaging will change because we don't know what is coming next in terms of specifics. We don't know if the next surge could be a more transmissible variant that also causes greater morbidity and mortality. Will it be something that evades vaccines? So some of the specific messaging is yet to be seen, but we are expecting for our current guidance to be guidance just for this recovery phase, however long it lasts. And part of what we have been hearing a lot through the course of the pandemic is that individuals want to make decisions for themselves. They want to make decisions about when to mask. And I'm not talking about healthcare facilities here, I'm talking about community. But they want to make decisions that work for themselves and their family members. And so we're trying to put a lot of materials out there that tell people when they should make those decisions for themselves. So what types of factors to consider? So those factors would include your own personal comorbidities. Are you immunocompromised? Are people around you immunocompromised? Do you have young children who haven't yet been vaccinated? What type of setting are you going into? Is it a crowded indoor setting? What's happening in your community? And so we're really empowering and encouraging people to make those types of decisions for themselves. But we also want to ensure that people feel comfortable masking if that's what they choose to do. So even though we're in this lower risk time period, there may be people who want to continue masking when they go to the grocery store, when they send their kids to school. And we need to normalize some of that behavior and normalize those choices. Just flashing up here some of our newer isolation and quarantine guidance that talks more about personal or household contacts rather than the CDC definition of a close contact, which talked again about 6 feet and 15 minutes, just because I think it's hard for schools and hard for other settings to keep up with that level of case investigation and contact tracing. One of the things that I do want to point out about our phases, and as we cycle through these pandemic phases, is that the pandemic phases may not completely align with the new CDC metrics. So the pandemic phases are really designed to be more proactive and predictive rather than looking at where we are in terms of current cases. So it is possible that we could shift into a readiness period, even though case rates are still low, based on a threat that we see coming in the near future. So if there is a variant of concern that we think is coming, it's on our doorstep, it hasn't quite arrived yet, we could shift into this heightened state of readiness even before we see any shift or bump in our metrics. I will spend a couple of minutes now talking about BA.2. So I'm sure you're all familiar with the BA.2 subvariant. It's been around on the news and lots of reports coming out on BA.2 from other countries. And of course, we here are following this very closely at the state level. So this slide is from the UK technical report that they issued earlier this month. And they are really seeing a predominance of BA.2 in the United Kingdom. And taking all of their data into account, as well as data from other parts of the world, we're really seeing that BA.2 is more transmissible. It looks like it's about 30% more transmissible than the original Omicron strain. And that itself is somewhat concerning. However, the good news is there does still seem to be protection from vaccines, so protection from severe outcomes and death. And there does appear to be some cross immunity between the original strain of Omicron and BA.2. So for a country like ours that just went through a huge Omicron surge, there is likely to be some cross protective immunity from that surge. But we are watching BA.2 very closely, and we can definitely see that what happened in the UK, that the number of cases did rise as the proportion of BA.2 went up. But important to keep in mind that there were some other changes in the United Kingdom in particular. So here I've got a couple of graphs. On the left, we've got daily new COVID cases per million, the United States versus the United Kingdom. And on the right, we've got deaths. And so what we're seeing here is that the United Kingdom, like us, had a very sharp Omicron peak. And the timing was pretty close. They were a little bit ahead of us, but also had the same sort of sharp Omicron peak that we had. And whereas the US has continued to trend downwards, the UK started trending upwards before they had really come down from that Omicron surge. And part of this is, I think, BA.2 is just so incredibly transmissible, but the other part is they did loosen a lot of their restrictions. So after talking to some of my contacts in the United Kingdom, what we're seeing there is lots of changes in terms of legal requirements. So legal requirements around quarantine and isolation have gone away. legal requirements around masking have gone away, and there's a lot of encouragement telling people to get back in the office. So some of the things that they are actually describing are things that we either didn't have here in the US or that went away quite some time ago. So they are nonetheless seeing a rise in cases, and sometimes the US does follow the UK trajectory pretty closely. But the good news is that their deaths have not gone up in the same way. Now, of course, this is a lagging indicator, and it's possible that we could still see a rise in deaths in the United Kingdom, but we have not seen that happen yet. So something that we are following very closely. There are lots of other countries that have seen a big surge of BA2. BA2 has taken over in countries like Denmark, the Netherlands, Austria, Germany. And what's been interesting is that the rise in cases has really been quite different in each one of these countries. And I think a lot of it has to do with what mitigation strategies they still have and how much society has opened up. But we continue to follow what's happening with BA2 very closely. So we are seeing more BA2 here, and we are watching these reports, although it's difficult to really get the complete picture because we are not doing a whole lot of sequencing. Hospitals are simply not sending us the same volume of isolates to do sequencing on. So if you are working in a hospital microbiology lab, please do send our Bureau of Laboratories more samples for sequencing. And then, of course, we're looking at wastewater. And it's not the only piece of evidence we need to look at, but when we look at the big picture, I think wastewater is an additional component that really allows us to flesh out the big picture. What's happening in communities? How are our case rates doing? What's happening with hospital systems? How overwhelmed are hospitals? And then what's happening with wastewater? So all of this goes into this forecasting picture to really tell us what we should be expecting in the upcoming weeks. And lastly, I'm going to talk a little bit about the future of public health post-COVID, or rather with COVID, because COVID is not going anywhere, as you know. But we've learned a lot of lessons from this pandemic. And so it's always good to think about the future of public health and what the future looks like. So this was a recent MMWR that came out looking at mental health symptoms in public health workers, showing that more than half of public health staff had some sort of symptoms. And really, this goes to show some of the strain that public health staff have been under. And for all of you working in infection prevention, you are no stranger to this type of strain and pressure and some of the conflict that has come about from the pandemic. I think there's been an erosion in public trust. The way that we're able to interact with the public as healthcare professionals, public health professionals, has been forever altered over the last few years. But this is concerning in terms of our public health workforce. And harassment of public health officials has been really widespread during this pandemic, which is something that I think should concern us all. I think it is probably fairly similar to what's happening in hospitals. When we have the discussion portion of this, please correct me if I'm wrong, but after working in hospitals in infection prevention, you all do not have an easy job either. And it's a lot of the same issues where we're trying to collect data and trying to make decisions on a community or hospital level. And I think that we really need to have public trust in order to do some of our day-to-day activities. So this has been something that has really been troubling, and a lot of public health staff have left. We've had a mass exodus of public health staff over the past 2 years. So we've been talking a lot internally and now externally too, as public health, about how do we build a better public health workforce and system moving forward? How do we take the lessons learned from COVID and build something better and stronger and more resilient? And the two key parts of this is to build a public health infrastructure that is resilient and that can withstand future threats, but also to build communities that are resilient and that are able to withstand threats and conditions that may arise in the future. So this is a little bit of brainstorming that has come out from from some discussions with the Public Health Advisory Council, which is one of the groups that I chair. And we've been talking about how to move forward. And so number one, the goal is to prioritize equity in everything we do. And we've seen what inequality and what some of the disparities have caused in terms of vulnerable communities being hit hard by COVID. So we want to prioritize equity in all of these activities. But the first action is, how do we strengthen public health infrastructure? How do we make sure that there is sufficient financial support, that we've got the data management systems we need, that we have the capacity we need for future outbreaks and threats, including workforce? And then how do we build back our relationship and our communications? How do we regain the trust of the public? And part of that is making sure we've got relationships with communities, that we're having these types of conversations with communities, that our messaging is unified. And that's part of the reason why I love having conversations like this, because you all are our public health advocates and partners in hospitals. And so if we're all using the same terminology and talking about COVID in the same way, I think that can be reassuring for the public rather than hearing disjointed messaging from different sources. And then of course, we have to ensure that we've got accountability. So that is the end of my presentation. But hopefully this is somewhat aspirational, taking the lessons we've learned from COVID and really using them to build back a better public health infrastructure and better trust, better relationships with communities. So happy to have discussion or open it up for questions.
Thanks, Dr. Bagdsasarian. That was a great presentation. I don't see any questions dropped in the chat yet, but we'll give our members some minutes here so that they can think over what was presented and come up with some questions for you. I will start. I did have one question. Great data that was presented. I was just curious, at the state level, do you guys look at, the distribution of the cases by origin, where the cases came from, such as from a home or a long-term care facility or jail or prison?
Some of that data we can look at quite easily. So when we're looking at a case and an address, and if that address is a correctional facility or a long-term care facility, then that becomes a little bit easier. But one of the things we've seen, and this gets back to this issue of erosion of trust, is when we were actively doing case investigation, people didn't want to give us that type of information. So whether the case was acquired at school, at a sleepover, at an after-school activity, that type of data has been very hard to piece together because people simply didn't want to cooperate with case investigation. And part of what's happened now is that because case investigation was so fraught and so difficult initially, it really was not successful in the United States the way it's been successful in countries in Asia, for example. So I lived in Singapore at the beginning of the pandemic, and case investigation and contact tracing worked phenomenally well because everyone gave a detailed account of where they had been and where the exposure happened. But if people don't want to give you that information, then case investigation and contact tracing becomes meaningless. And so one of the things that we're doing now is we've moved away from routine case investigation and contact tracing. And in fact, our most recent quarantine guidance, we really rely on individuals to tell their own contacts. So if you have COVID, the advice is, please tell your contacts and tell your household contacts first. And the way that we've tried to define household contacts is not just people you live with, but anyone that you're sharing a dining space, a bedroom, a bathroom, a kitchen, anyone you carpooled with, if you've had a sleepover. And those are really the people that we want you to tell first. But unfortunately, we simply don't have the infrastructure, the staffing, nor do people want to cooperate with us to have public health continue with case investigation.
Thank you. There's a question from Rebecca. There are also big differences in wages / financial compensation between public health / local health departments and IPs and healthcare and / hospitals. Is this being discussed at the state level as well?
That's not something that's come up, and I would love to hear any further details on this, what you think the disparities are, and do you think it's causing problems or issues?
Rebecca, are you on the call? Did you want to unmute?
Hi, I'm here. Can you hear me? Oh.
Rebecca, are you there?
I'm trying to be here. Can you hear me?
Okay, we hear you.
Yeah, I noticed, I think we see a lot of people from local health departments go into the hospital system. At least I've seen that happen in Southeast Michigan. And, even looking at physician postings, you can see a large disparity in, the local health departments who I can't imagine how much stress they've gone through. And it's really been a different world. We've been in our own silos, infection preventionists in healthcare and the local health departments. But I definitely think it's worth exploring from the state level because I think you usually see one direction going from local health departments into the field of infection prevention and healthcare. And from the experiences I've seen, again, it is quite a difference in compensation. And I think you guys, it's worth looking into. You might see more maybe folks even interested in going from the healthcare sector into local health department. But I don't think right now we see much of that happening in infection control.
I think that's a great point and something for us to look into. Not something that I had actually considered myself, but if there are such big pay disparities, then I can see how there could be this unidirectional flow of talent. But not only pay, I think that for many of us who work in public health, we see this as a calling. We see this as much more than a job, but it's very difficult to function even in a job that you love if you're being harassed, if you're receiving death threats, if you're being sued, if you're constantly threatened with losing your job. So I think it's also the bigger picture. So, the financial compensation is part of it, but how do we just make this a more sustainable workplace? Because no one should have to work in a setting where they're being harassed or threatened. I'm sure you read the newspaper articles. These are my colleagues, these are my friends, and some of them have been threatened with their lives. Their families have been threatened. There was a local health department official who his car was forced off the road. This is all just part and parcel of working in public health during this pandemic. And I think it's really, really unfortunate. So Rebecca, thank you for raising that point, and I will look into it with some of my staff.
One other question we have is, how have other facilities dealt with the discrepancies between community guidelines versus hospital guidelines for COVID from CDC? So for example, CDC is recommending 5 days isolation for community members, but are still recommending 10 days for hospital patients. We have had pushbacks from providers and patients with the extended isolation in the hospital setting.
Is that something the group would like to brainstorm and share ideas on how they've handled this?
This is Amanda from U of M. I can just share what we've stuck with the healthcare recommendations for the hospital and even our clinic setting, so have been more protective here. And it is confusing, and we created a variety of educational materials to try to explain the why. And it's, I think it's something we have to have discussions about a lot, but we've decided to sort of err on the side of caution in all of our healthcare spaces. We're running into a similar issue, I think, like with the new CDC way of looking at your community, like low, medium, high. So we've used that as a big driver in making decisions in sort of our non-clinical buildings, if you will. But for the healthcare related and clinical buildings, we're really looking at that old risk score, you know, I think we're D right now, you know, or whatever, but we kind of use that as a big driver for that. And it's hard to articulate to people because I think that people are ready to stop the insanity. They feel really like we're done. We don't have to do it here. Why do we have to do it here? But that's how we've been operating so far.
How are other hospitals operating? Thanks, Amanda, for sharing.
Hi, this is Kim Greenwald. I'm at Pine Rest and we're a behavioral health facility. So our population is a little different in how we get people in. We have a walk-in process and those that come to us from EDs. The EDs are all tested before the ED patients are all tested before they come to us. But our walk-ins, especially if they're particularly behavioral, can get really, really tricky. So we have stayed with the healthcare guidelines, and an example of this is we had a young lady who came in. Mom said, oh, she was negative on a home test and she'd gone to an outlying ED, and so they didn't retest her. Well, our policy is we'll test you. Lo and behold, she was positive. So then we had exposures, et cetera. So we are really sticking to the guidelines because ours is just a different population.
And just some comments from the chat. So it looks like Spectrum Holland and BOMA is doing the same thing as Michigan Medicine. Is there anyone else from other facilities that would like to share?
Hey, ciao, it's Rebecca.
Hi,
I'll
Rebecca.
fill in as a board member. We should all talk, right? One thing we recently did, and I work at a small surgical hospital now that's independent, we changed up our signage. It had previously said mask up, it's the law, and apparently that was really creating some tension. People did not like that, visitors and staff, because there has been a lot of confusion with MIOSHA and this where the healthcare ETS stands and what we have to do versus what we should do. So one small thing we did is change the signage up to say masks are still required, and we're really focusing on the wording about vulnerable populations and protecting people, and that seems to help. We also created a script for when people you know, are unhappy and start complaining about having to wear a mask, and I think those things have helped as well.
Great, thanks Rebecca for sharing. I don't see any additional questions in the chat. So I'm just gonna close out early to our group, and thank you again so much, Dr. Bagdsasarian, for taking the time from your busy day and be here with our chapter to share your knowledge, inform, and educate us on the ongoing COVID-19 pandemic. Thank you for your leadership and for serving our state, and we look forward to the day that we would be out of the woods of this pandemic. And we just have a couple of slides for reminders to our members. The slides will be, I saw there's a question that says, will the slides be available? They will be available after this presentation. Our 2022 events flyer was sent out last week. Save the dates for our April and May virtual education sessions. And then we do have two events that we are planning to be in person. So in August, we're looking to have a member celebration for APIC's 50th anniversary. And then also we're hoping to offer an in-person conference this fall. So stay tuned for more details, and then any changes or additional details will be communicated via email. If you guys have any questions, please feel free to direct them to Kelsey and I, and our email addresses are on the slide here. And then one more reminder, there was also a survey that was sent out last week along with the flyer. After 2 years being away due to COVID-19, we're very eager to host our annual conference this fall. And so while the COVID-19 pandemic is ever changing, we appreciate your input about an in-person event and whether you will be able to participate in an in-person event later this year. And so please take the time to fill out this survey. I think it should take no more than a minute or two. And the information will be used for planning purposes only. And then for session recording, so all webinar slides will be posted to the APIC Great Lakes site. Thank you, Rebecca, for doing that. And then don't forget to subscribe to our YouTube channel where our session recordings will be posted there. And then one last slide is about our job posting. So if you have an open position and would like to post to our webpage, please feel free to email Rebecca and then she can get that job description onto our webpage. And that's all we have for you guys today. So thank you again for joining us and have a great day. And we look forward to seeing you guys virtually in April. Bye, everyone.